Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Ladies and gentlemen, welcome to the final session of this afternoon's program. And so the topic for this afternoon is healthcare reform. Are we really serious? Now, if I look at this topic, actually, this topic pertains to Malaysian settings. The Malaysians have to ask themselves, are we really serious? Our two neighbors have already started, so they have proven to be serious. But we also want to know from them, so you've started, how much more serious can you go? So as an introduction, I think Prof. Aljunid would like to have a presentation first and give his viewpoints on this. We'll go a few rounds, but I'd like to say that we need to I'd like to get this over by 3:30 because Professor Supasit has to leave before 4:30, so I think we have another program following that. So I'd like to invite, first of all, Professor Emeritus Dr. Syed Aljunid.
Thank you, Prof. Husni, and thanks everybody for coming to the last session. The topic on how serious our reform is very interesting. In the plenary, Prof. Supasit has discussed quite a lot from Thai and also from experience from other countries. But I want to reflect on Malaysia, and I want to just show you 5 slides related to Malaysia. How serious are we going towards the health reform? I'm going to tell you about our Malaysian white paper. This is the document that are supposed to guide our health reform. And there are 4 different pillars in the health white paper. The first pillar is actually to transform health service delivery. Number 2 is actually looking at the health promotion and prevention. And pillar number 3 is related to health financing. And pillar number 4 is to actually strengthen the health system governance and also foundation. So under pillar 1, when we say transforming of health service delivery.
Recording in progress.
It covers activities like giving priority to primary care, to optimize the hospital care services, and 2 important things. I think Dr. Lutfan will touch on this. Regarding the digital technology, which I think we want to do this quite a lot, and also increasing the public-private partnership. Under pillar number 1, it will cover this area. So we are looking at the collaboration and interaction between the public and private facilities facilitated by a strong policy. And the gist of this is actually the relationship between public and private sector. And we are looking at the probably the provision of the services by the private facilities, but the financing will be done by the government. This is one of the models that we are exploring quite a lot, and this has been emphasized a few times by Ministry of Health, and we are looking at how they are going to put this to work in the next few years or so. The second pillar is actually to give more priority to preventive services and health promotion. In other words, there will be a lot more coordination in terms of with the various parties involved in public and private sector in trying to ensure that we are able to deliver health promotion and health prevention in a more effective way. So there will be a lot of incentive that would be given in order to provide pro-health practices and also behaviors. So we are looking at working with the community, working with the various stakeholders, and try to touch the community, in trying to promote healthy lifestyle and also provide best practices of intervention on preventive health services. Pillar number 3, which we have been discussing this quite a lot since yesterday, is focusing on equitable health financing, where the government is going to increase the investment for health. We are trying to move away from 4% of the GDP to much higher level, and to ensure that we provide the comprehensive health services that are affordable by the population, and to make sure that the money that we actually prepare and for the consumption of the health services are being spent wisely. So that is the under the health sector reform. There are many things that has been said, especially the focus on high out-of-pocket expenditure, long waiting time in healthcare facilities, shortage of drugs, and all that. So I think that is the third pillar. But I'm going to skip this. Let's go to the fourth pillar. The fourth pillar is actually to strengthen health system foundation and governance. Under this, there is a plan to restructure Ministry of Health of Malaysia to strengthen the policies, legislation, and regulation role of Ministry of Health, to fortify the health workforce, and then stimulate research and innovation. But then, what probably will happen is that these are the 6 current roles of Ministry of Health. There are at least 6 different roles, including education, R&D, policy making, and also regulation. But in the future, MOH role would probably be focused on 3 important areas, which is health policy and development, monitoring and evaluation of services, and small part of it will be on as a service provider. So we are talking about a situation where only certain services that are very crucial that were provided by Ministry of Health. The rest would be decentralized or being played by other policymakers. I think that is the situation in Malaysia, and I think we are going to see whether the government will really walk the talk when it comes to this. Okay, I will stop here, Prof. Husni.
I would like to invite Dr. Lutfan now first to give an overview. This is the first round, by the way, to give an overview of, you have already started, your country has proven that it's serious, although probably Thailand has been the first established, but you started now. How much more would you like to reform in that such situation, which means that what have you learned so far as to now? So there are 2 aspects here. One is, how did your reform come true? How did you become so serious? Well, how did you manage to have that political will and whatever wills that you have to start this thing? And then you've come this far, and what are the lessons learned? If you can give us an overview on that. Thank you.
Yeah, thank you, Professor Rusni. But first of all, I would like to admit that actually Prof. Laksono had asked me to sit in this to actually also give an example of reform in our institutions. And this is the things that I think are very important also, that now Professor Laksono expect that the younger generations should also do something to continue the journey, which is then leading to the sustainable ecosystem as well. And yeah, responding to the questions, how serious are we on this health reform is actually can be debatable, but I think we have to acknowledge the effort that has been done to do the reformations. Just for example, like there are many efforts that actually aim to improve the efficiency, the effectiveness, as well as the improvement of the quality of the healthcare. Just for example, now the Ministry of Health is also do the what's so-called health transformations, which is maybe the list is not as what Professor Syed put, but there are some component which is I think strongly support the idea what Professor Syed is already mentioned. Just for example, like one of the transformation is related to the strengthening health system, strengthening the health workforce, as well as the use of the digital health to facilitate the reformations. And there has been also discussions that the Ministry of Health used the transformation, which is the terminology was actually described by Professor Laksono yesterday, that in to some extent it's like to change the fundamental and also more probably how to say more complex. It's not only to improve the current situations incrementally, but also then to change the mindset. Just for example, that we used to do the policy making using the method which is usually based on the document from the previous report, and we do it incrementally and then change based on the assumptions. It's not based on the data, since that it's not easy to get the data, and usually the government rely on the survey, which is usually conducted every probably 5 or probably more than 5 years, and of course this is not really showing the real time. But now there has been effort also to use the real time data, and of course this is not easy, and have to change the mind, have to change the culture also, and also have to use the digital technology to support this. Yeah, this is just an example of how serious we are, and I think we learned a lot since that we need also to collaborate not only within the Ministry of Health, but also need the collaborations with others, such as like the academia as well. Yeah.
Thank you for the overview. Personally, I'm quite impressed by the fact that Indonesia, which is probably the largest archipelago in the world, with thousands of islands and 270 million population, despite these obstacles, you are able to be the largest provider of social health insurance in the world. And to me, that is very, very remarkable, something which I think not many countries have been able to achieve. And the fact that you are very much distributed across the equator makes it even more difficult. But thank you for some of these important points, which we'll get back to you later. Professor Supasit, what about your side of the story in Thailand? I think Thailand is probably the most established. I've read a lot about your articles, especially for my own thesis on social health insurance, and I think very much impressed, which I think you have that area where you cover tax as well as social health insurance component. So could you tell us a little bit of how this political willingness managed to overcome everybody else, and how you can start when for the last 30 years Malaysia has been extremely good in talking and talking and talking. I remember I have had the Malay Mail headlines 30 years ago saying that the then Deputy General of Health was saying Malaysia will start with its own national health finance program. That was 30 years ago when I was still in private practice. So tell us a little bit about how Thailand managed to succeed, how its politicians managed to overcome their whatever issues they have and start this ball rolling. Thank you.
Yeah, as I wrote in the abstract book that the reform in Thailand may not be very interesting issue as such at the moment, but we still have the changes, like I presented before lunch, that politicians want to gain popularity further and further, and how can we how can we have the system in place, communicate to the people, so that policy, each policy will must have financial backup. Back to the your questions, that actually we have before universal coverage, we passed the Social Security Law, Social Security Act, of which the fighter for this act, he fought for 26 years. Yeah. He's the labor economist, and he said that he fought for 26 years because once he raised the issue, social security was equate to communism. Yeah. And that's a tricky word. That's the word got a lot of opposition. Yeah. But once we passed the law, yeah, it's the so that's fighting within the parliament and the passing the law itself took 26 years. But once we passed the law, what we learned, according to the source of finance itself, as I discussed earlier about the carbon index of progressivity or the based on ability to pay. The setup of three sources of finance: employee, employers, and government subsidy. Also, government put the third part. The first part is from employee. We set the figure at 5% of the salary, yeah. But we start incrementally from 1.5% and increase because we start with 4 benefits and we reach a mature stage at 7 benefits. So we gradually increase from 1.5 to 5%. But the point of inequity is that because we cap the income at 15,000 baht a month. Yeah. So it's less than 1,500. It's about 1,500 ringgit. Yeah. We capped the percentage. The percentage of contribution is 5%, but we capped the income. Whoever earn more than 15,000 baht will be will contribute only as if he earned 1.5. So just pay 750 baht only a month. Yeah. Even you are very rich, like Prof. Lazuardi said, his friend is earn a lot. Yeah. So if he earn higher than that, then it just contribute to that only. So the change of this minor law or the interpretation was difficult, also difficult. So this somewhat the experience what the Malaysia has drafted. Yeah. So that one point. The other point, I think the other point we can learn from others, also other schemes. After the Social Security scheme, 5 years later, 1995, we passed the Traffic Accident Protection Act, which we allow the private insurers to come into the compulsory scheme. We call compulsory scheme because every owner of a vehicle must pay to the fund. But the carrier, we allowed private insurers. And we realized that we have to change that because private insurers will take benefit from that by denying payment to the hospital, ask for many documents, which difficult to provide after accident. Yeah. Why not compensate rapidly? Yeah. Again, this law, this is the level of law act itself. Very difficult to change. It cannot change. So that's then we have to, if we take the as so my point may be that when the context of law drafting, we should have the principle in the law, whereas the details can be the minor, the bylaw that can change easily. That may be some lesson learned.
Yeah, thank you. Just to clarify one point here, you have three different systems in your finance, in your schemes here. I gather that they do not exist at one point in time. They were existing at different levels over a period of time. So when your reform was started, it was just a matter of coalescing all this that's existing and paving the way forward. Am I right to say that?
It's incremental, but since the UC scheme come last and cover most, so we said that for those who are not covered by the previous two schemes are totally covered by the latest scheme. So the latest scheme can innovate, have innovative measures, but the other two schemes is just status quo or the followers, if law allows.
So there was a brilliant politician strategy in that sense, making use of the time and circumstances to when to start to get going. We've been having, back to Prof. Aljunid, I think you and I have been together for years. You've been fighting for public health and all these reforms, and I have been fighting for primary care in both at the academy level, at Wonka level. I think the frustration is felt by both of us, especially so you now, because you are in that position. A couple of questions first. We got 5 pillars, right? As you were saying. If ever you were given the authority to start with, I don't think you can start with all 3 at one show because it's a bit difficult. Out of those 3 that you mentioned, which would be your priority to begin with?
That's a very difficult question to answer. We have 4 different pillars. And to me, maybe I'm a bit biased because I'm health economist. So pillar number 3 on health financing attracts me most actually. And that might be the most difficult pillar to tackle. But without that, the other 3 pillars will not be able to survive. If you are talking about in terms of how easy and feasible to actually carry out, all within, if you want to choose between all these pillars, in terms of feasibility of doing it, I think pillar number 1 would be much easier because trying to actually improve the delivery system, we don't need much effort in terms of looking at providing services properly, high quality. That's always physical. But one major component inside that particular area that is very hard to do is actually public-private partnership. Because we can say public partnership can be carried out, but how deep and how significant this partnership are. In 1992, I wrote a thesis on public-private interaction. You can still see my thesis in the London School of Hygiene. I look at the study. I did a study in one of the rural districts, and to look at how public and private sector interact with one another. These are in the 90s, when we are looking at that. And major things that the public-private partnership is difficult to do. Simple thing like, for example, disease notification. The public facility expect the GPs to do the notification, but the GPs said that if they notify the patient, then the patient may not again come to their clinic, you know. So these are some of the things that have been there. When it goes into a higher level of public-private interaction, for example, sourcing out Ministry of Health services to private sector. For example, this morning, Brigadier General Arsil was telling us about during COVID-19, where Ministry of Health tried to use these services, especially ICU services in the private sector. We come up with the money, about 20 billion, to support all those exercises and pay for these services when we want to actually send patients to use ventilator in the private sector. But what happened after that? The money is all finished, and the government stopped that. Even during the pandemic itself, they already stopped that because it's too expensive. Our costing, if we just pay the services for ventilators for 5 days of ventilator use in the private ICU, it costs about 30 to 40,000 ringgit, which is very expensive. So the thing is that under pillar number 1, certain things can be done easily, but it will not be that easy if we don't have a financial mechanism to tie it up. So although it can be done, some of it, but still pillar number 3 have got a lot of things that can support the first pillar, the financing part. So the easiest way to actually make positive interaction between public and private sector is to tie it up with the financial scheme. So pillar number 1, that it is, I think that can be done quite easily. Pillar number 2 is actually to promote public health services and preventive services. We have a lot of activities being carried out in Ministry of Health, but it has some limitation. For example, we want to make sure that general practitioners can provide preventive services. For example, provide a smoking cessation clinic, clinics for healthy nutrition, clinics to reduce body weight, and also weight reduction clinics. The mechanism is there, the technology is there, but again, it relates to funding. How can we incentivize the private sector to do this? So again, it relates to pillar number 3. So we can actually promote this, but nobody will pick up this unless you give some incentive scheme for them to actually do this. Because most of our GPs, general practitioners, can actually do this, can carry out this, promote these services, but they have to be funded, of course. And if we depend on out-of-pocket payment, nobody is going to pay for this kind of services. Pillar number 3 and pillar number 4 is quite difficult. Pillar number 3 is the most difficult on health financing because we have been trying for more than 30 years, yeah? As Prof Husni said, 26 years in Thailand. So I think we are not that bad. Maybe we can wait for a few more years, you know, before we really retire to see this. Pillar number 4 is actually to transform Ministry of Health from the so many multiple roles that they have now, to reduce their roles into specifically focusing on policy making, enforcement of certain regulations, and also focus on delivery of specific services, like, for example, the National Cancer Center, National Infectious Disease Center, but not the usual services that we see providing secondary and tertiary care. It means that there is need a lot of restructuring. And one thing MOH have to give up there is research and training. So in that particular reform, we proposed, I was involved in that group, we proposed that MOH would not so much focus on research, because research should be outsourced to Ministry of Health. Because at the moment we have a big number of staff being locked in the National Institute of Health, and their research and output was also not that convincing. So we might want to close some of this. When I mentioned this, a lot of my friends in NIH do not want to be friends with me anymore. You know, we have 600, I think around 600 medical officers over there, and most of them are not trained to do research. Why don't we just close some of it and then outsource or actually attach some of this institute to the universities, and they can learn much better on that. So I think that is pillar number 4. I think that can be done, but the issue is that is there any support from Ministry of Health to go into this area, you know? And of course, the most difficult is the pillar number 3, to start the health financing scheme. And until today, I thought that we have seen some tunnel at the end of the light, but the light is getting dimmer and dimmer, you know, as we travel through the tunnel. So our current government, as you can see, that is quite weak. We have 4 different prime ministers over the past 5 years. One is in jail. The other one, the son-in-law, is about to go to jail as well. And then we do not know what happened to the rest, you know. So political will, as you all has mentioned in or responded to my Slido yesterday, is a real issue that have not been able for us to push this forward. Yeah, I think I'll stop there.
Thank you. Dr. Lutfan, 2 years ago in Bali, Wonka Regional Conference, I was the president of the Asia Pacific Wonka region. I've had the privilege of having a Zoom meeting with your Minister of Finance, Pak Budi. And I was impressed, although he's not the doctor, but I was very much impressed by the fact that he told me, Bapak Husni, in his Indonesian terms, saya Menteri Keuangan, saya banyak wang. I am very eager to transform my primary care services, development of family medicine. Can you teach us how to do, you know, in that kind of situation? So I've had good relationship with my Indonesian PDKIs and all that. And in the white paper 2 years ago when KJ was our minister, I presented a paper on reimagining primary care, how primary care should change in Malaysia based on the experiences of other regions I know in my Wonka organization. But I'm happy to know that my colleagues in Indonesia are pursuing this very aggressively. And how much of it now has the government now, I believe, realizes the importance of primary care. In any primary care, in any healthcare reform, you realize that most countries take the stand that primary care reform is the most important. And these are learned even in the Scandinavian countries as well. So what would be your impression now? Would you all agree to this statement? And how much do you think this will help to improve further on your present JKN? I know you're a public health person, but I see public health and primary care, family medicine as going together. You know, both of us are in the same line. One deals with the family unit, one with the community. One cannot be living in silos. It's how we work together. But how much more does family medicine has to go in your situation?
Yeah, I think in terms of the strategy, actually the primary care is number one in our health transformations. So it's located in the first line of the health transformations. And I think this is showing the importance of the primary cares. But probably this is probably my opinion, which is may have a bias also, that in practical reasons, then all of the activity need to be conducted using the data. Just for example, now, like a primary care is also requested to do activity with the data, and I think this is the things that we actually put the technology at the lowest. We have 6 pillar of transformations, and health technology is in the 6 and but I think this is actually the things that will be needed by all of other pillar, including also the primary care. And nowadays we realize that, just for example, like if we talk about the financings, we realized that the budget allocated for the primary care is still somehow limited. It's only, I think, 30%. And it's also happened with, just for example, like human resources. Based on the data, we know that we have maldistributions. We actually still need a lot of more doctors. And also, I think in terms of the financing, we realize also that we should allocate it more on the preventive strategy. And just to highlight that one of the strategy to do the digital transformation is related to the electronic health record, which is now become mandatory. It was actually voluntary, but for quite some times, I think more than 10 years, it doesn't really work. And now it has been mandated, but it has been mandated that it should be mandatory to all level of the healthcare facility, including primary care. And now they realize that they have data which is then will be easier to do something on the field, and also have impact also to support the clinical management as well.
Thank you. Before I go on to Professor Supasit, back to what you were saying, Dr. Lutfan. I'm not the immediate past president. When I was a president, just immediately after COVID, I was invited to attend the Western Pacific region, although it was online, which was based in Manila. I was asked to prepare a submission on what the WONCA. WONCA actually stands for World Organization of Family Doctors. So I was the president of the Asia Pacific. So I put in the stand that the lessons learned in COVID was that, number one, governments must strengthen their primary care system. And number two, there must be increased use of digitization. We've learned a lot from that. I mean, even universities, when you had COVID, we had started teaching online, you know. Of course, there are certain defects, certain shortcomings, but the fact is we had to do what we had to do. So take it from there. I do agree with you that you cannot separate things together. In this sense, primary care or secondary, whatever it is, digitization is very important. And I think our YB Zul is also putting as one of his top priorities. Professor Supasit, what is the effect of primary care as a gatekeeper in the current system? How effective is it? The word gatekeeper is very sensitive. When you talk to secondary specialists and tertiary specialists, you know, even my Malaysian colleagues are not pretty happy, you know, when that's saying gatekeeper. But to put it in very rough terms, that's what it is, you know. So when I was doing my thesis, I was looking for the Bahasa Malaysia version, penjaga pintu. So a bit awkward, you know, but that's what it is. So, jaga gawat or whatever, right? So how effective has that been, the role of primary care doctors, which I'm in touch with now also, in that system of yours?
In my evaluation right now, it's still unsatisfactory in my aspect, because I have high expectation for I was criticized that I'm not doing research as much to support the primary care system in Thailand. And I'm obliged or the under the invisible contract to do that. Let me link what I've said to the one ID card anywhere, going anywhere. Is it jeopardizing gatekeeping system, or will it promoting the primary care system or family doctor or principal? As I said, having written in the abstract book, I like to turn the reform into the digital reform, digital health reform. And during COVID, family medicine proved to be a skeleton to provide quality of care to take care of patient at home, yeah, or in the community. But after COVID, like this morning talk, everything collapsed. But I think this is the point that if we, I end this morning talk with the just power. So the information power is one thing. So information power can be shared with the people or population or patients, and share with those who are close to the patients. So if family doctor prove themselves to be very close to the patients, so the genomic data or whatever, the utilization data or the prescription data, the medication that the patients take, then that sophisticated data, if we can make the reform and the digital literacy of the patients are imbalanced or the imperfect information, so the family doctor can be the positive agent to do that. Yeah. So this is the many things has to be done. Yeah. Yeah.
Yes, GPs being GPs globally, wherever they're not united in their stance. For some reason, even in Malaysia, we got so many pockets of GP societies, but the academy is responsible for training family medicine specialists. Prof. Syed, back to you. One more, just finish. Before we open to the rest, because a few things I didn't want to finish up.
Okay.
Just a short one. So what now is your take that now you are the technical advisor, and I followed you to the parliament recently to the select committee. What be your take now? How confident are you? In other words, you're asking the question, how serious are we? Back to this theme. How serious are we? How serious is Malaysia going into this health financing scheme? You and I have been walking up the stairs of Ministry of Health for donkey's years. I don't know. University hasn't allowed me to retire even at 69. So I hope to retire. I hope to see this through before I retire. What's your comment on that?
I think the good thing about situation now is that we have something that we can fall to, which is our health white paper. This is approved in Parliament last year. So at least the big principle is there. The only thing is that we want to make sure that this health white paper will not turn into brown and later black paper if we don't do anything in the future. So this year is very, very crucial. We have a new Minister of Health who has worked with our team quite positively. We have been called to present to the Parliament on our model, but of course, when we expose our model, the players become very agitated, But we have to tell them this is what we propose. I think when we went to the Parliament, how many of us? 13, 14 of us, 14 of us, from various institutions that I roped in. I think they listened to us. They was very happy to accept what we have given, but without the National Health Financing Act, the law that has to be created, nothing will actually move. So now I think we need to push the government to somehow start to actually look at drafting the National Health Financing Act. This is where the what we call the devil's in the detail. That is going to be done. I think we have to bite the bullet. We have to sit down. We have to start pushing it until this is being presented to the Parliament. I think we have to start to have the drafting team to start drafting the law. There are people who start asking us, can we borrow the law from Indonesia? I think it's easier. From Thailand, it's difficult. We have to translate, you know. Maybe we'll, if it is in English, it's okay. I'm going to discuss with Pak Laksono. Maybe your Health Financing Act, we can actually copy it. And then we try to promote this, because I think fundamentally a lot of things are quite similar. In Indonesia, you have the SOCSO or Social Security for the pekerja, yeah. What do we call it? Jam kerja. Yeah, SOCSO. So the system for pekerja, yeah. We have our SOCSO here. So I think this is the important step that we have to move forward. Health white paper is just a paper. There is no obligation for government to do it if they do not want to move it, you know. But to translate that really is, we have to push for the National Financing Act. That has to be said. I mentioned to the previous Minister of Health or the current Minister of Health that we need to form this act, and she told me that nobody informed her that we need to go into this act. Oh my God, no shit. I think, but she's no more there at the moment. But the new minister know that we have to move into drafting this law, present it to the Parliament, then we get the commitment. So they were saying that we need about 2 years. I think it's okay, we can wait, but at least something is moving, rather than staying stagnant at the current moment, where our system of health start to deteriorate. We don't want our competitive index to go down lower. We do not want the indicator for universal health coverage to come down further. At the moment, our score is at 76. Before we were more than 80. We have achieved universal health coverage, but it have come down. So the longer that we wait, the longer that the system will start to become stagnant and deteriorates. I think if anything I want to do now, I want to actually move forward, form a team, draft the National Health Financing Act, and then go to the Parliament.
Thank you for that last observation. Dr. Lutfan and Professor Supasit, one last question before we throw open to the floor. Would you agree, or rather, looking the other way, Prof. Syed wanted our Ministry of Health to reform its position instead of being the one-stop shop center, whatever it is, to limit its roles. How far has your Ministry of Health done this in that sense? Or are they still the one and only absolute power in Indonesia on that?
Yeah, it's, I think, 1 million questions, but I think there are several strategies that now has been actually conducted in Indonesia. To some extent, there are some which is really centralized, just for example, like the data and information, because this is the foundations to do the actions, and this is, I think, the things that Ministry of Health seems to use the authoritarian policy. But for the implementation, it seems that there are more respect to give the chance for innovations among health facility, even at the local level, which is, I think, very, very good, since that the one that actually really understood the situation and the context and have to do the intervention is they are on the field. But they of course have to, based on the data that will be then recognized by the Ministry of Health. Yeah, I think it's somehow mixed.
So there is some leeway in that sense, but the right hand is still holding it.
Yeah, yes,
okay. Professor Supasit? How authoritative is your Ministry of Health in this scheme at the moment?
um, change the changes should it come from insider or outsider, or if Archimedes want to move the world, he has to stay outside the world to to move the world. But within the organization, how can we make change? That's I think it depends on the context. Yeah. But back to our social security scheme. Some propose the amendment of the law that the 7 benefits, in order to be equitable with the other 2, that they are not contributing. So why not let we delete the health benefit with the 5% and let the NHSO to manage the benefit, the health benefit, but the scheme stay on and pay for the 6 benefits, and that can pay even better, yeah, because can save from the health benefit. So this is the issue of the ownership or some misinformation or disinformation, the fighting, the political fight between within the organization, because we have employee associations and so and so. So that's the things to be aware of, how to make a single system. But Prof. Laksono said single is not good. Better stay away from single. That the change from the inside is also difficult. Yeah.
Well, thank you for your thoughts on that. Ladies and gentlemen, we have another half an hour to go because Professor Supasit has to leave at 4:30 and we have another program. I'm throwing this open to the floor to anyone who wants to give their opinions or perhaps to have any queries on what our 3 legends have been expressing about. Raise your hand, please. Yes. And introduce yourself.
Thank you very much, Doctor. Yeah, my name is Haryo. I am from Universitas Gadjah Mada, and I'm very intrigued with what Dato Prof Aljunid proposed in the last slide, that the Ministry of Health's role needs to be reformed, not only just doing lots of things, but also only 3 that you mentioned, that is to strengthen the health policy, to do the monitoring and evaluation, also a little bit doing the service provider. It is interesting that in my observation to the Indonesian reform right now, it is in reverse, so that the Indonesian Ministry of Health wants to control some of the things that previously not being controlled by the Ministry of Health. And then especially when we talk about the education, so mostly previously education is all part of the Ministry of Higher Education, but currently the education of medical specialists especially and subspecialists is now being in control by the Ministry of Health mostly. And also when Dr. Lutfan said earlier, it's about the health informatics. So the health informatics itself, the structure of the grand design, what we call Satu Sehat, it's from the national government. So the product is from the Ministry of Health. So it is quite interesting if we talk about these 2 reform that been developed between Indonesia and also further in Malaysia. But I'm just curious about what can we learn from the previous health system in Malaysia that you mentioned earlier about the Ministry of Health that have lots of roles in there. that may lead to that maybe the Indonesian settings can also be prevented, like what kind of issues and what kind of situations that need to be addressed if we currently are going to the stage where the Ministry of Health have lots of like tasks, not only just to govern but also to implement like that.
Yeah.
Yeah, thank you very much.
Thanks for again raising this very important issues in Malaysia, and also you compare with the situation in Indonesia. I think in Malaysia we are seeing our Ministry of Health is doing too many things at the moment, and the concepts that we are seeing here is like you are jack of all trade. When you are jack of all trade, you are master of none. So at one time when we are trying to do everything, you won't have all the expertise to do that. And one clear issue is on the research and development. MOH have got so many institutes, but they don't have enough staff who are trained well. So for example, when during the COVID-19, they collect the information, but to do the data analysis and also prediction, they cannot do that because they don't have the expertise. The experts are all in the universities. So that's why you need to actually reorganize it so that they let the expert do the work that they are best for, rather than you are putting up another facilities and then you don't have enough staff to do that and you collapse. So to be efficient, we have to change it. I think situation in Indonesia is slightly different from Malaysia. I think the government is, as far as I know, they try to reorganize the role of the MOH to take over some of the roles of the professional association that are having too much power to control the distribution of human resource. I mean, you know, I visited Indonesia quite some time. Tomorrow I'm taking a flight to Indonesia also, to Jakarta. I'm visiting one of the hospital. The specialists, if they want to go and work in a certain area, they got to get the approval of ED in that particular area. So that's why MOH was not very happy with that. In Malaysia is different. The issue of training, for example, we are actually have to reorganize last few weeks with the Medical Act Law number 15, where MOH now, instead of following what in the pillar number 4 of the white paper, they actually, what happened, allows MOH to train specialists now through what we call parallel pathway. This is against that particular spirit of the health white paper, where we are saying that the training should not be done by MOH. So a lot of people, especially in the university, are not very happy with that, because now you will produce specialists through another specialist training program organized by MOH, but it is not coordinated by Ministry of Higher Education. In Ministry of Education, we have an agency called medical, the MQA, Quality Emulation Quality Agency. MQA will vet through all the public program to train specialists and also in all specialty. But now if we have the parallel pathway, then they will not have to go through that, which means that the local program are much more scrutinized, but the other program which is done by parallel pathway, bringing in people from attending fellowship program from overseas, will have a much easier way of becoming a specialist. What we are scared is that in the future, you might produce specialists that does not fit to be a specialist to work in the Malaysian scenario. I think Medical Act 50 has been fiercely resisted by most of the universities, but it's been approved in the parliament. To me, I think that is not right. It's against the spirit of that, the spirit of the health white paper. So my stand is quite clear. We don't support that. But it's already been approved by the parliament, but now they're going to write the regulation. At the regulatory level, there might be some way that this can be improved. I believe that MOH have to actually focus on their strength and leave other parties to be involved. And remember, health is not owned by Ministry of Health now. especially when we talk about One Health. Everybody will have a contribution on that. So the concept of saying that MOH is a custodian for health, which I never accept from the day one I'm in the health sector, is no more valid nowadays because health belongs to everybody. It's not only Ministry of Health. Yeah.
Thank you very much, sir.
Any other questions from other countries? What about, yes, young lady, please.
Yeah, thank you. Actually, I'm from Indonesia and I'm curious with the health transform in Malaysia. When Professor Dato tell us about the reduce the role in the Ministry of Health, especially in the research area. I'm so curious because it's a similarity in Indonesia that the Ministry of Health researcher in the Ministry of Health become change the role, become a policy analysis. And I'm just curious what the new role the researcher in the Ministry of Health, if they are reduced if they are cannot to conduct the research in the Ministry of Health, and how to the Ministry of Health bridge the evidence into policy process when they are develop some health policy. Thank you.
Well, basically, that is the argument given by people in the research sector in Ministry of Health. They are doing research, and this research will be given back to Ministry for consumption. But on reality, when we look at the output of this research, this one I'm not going to criticize NIH. You look at the outcome. The outcome was very bad. The outcome was not actually up to the standard. In the university, we are supposed to produce at least 2 publications every year, every lecturers. But when we look at the output of researchers in the research institute, especially in MOH, it's very poor. It's less than that. So we have so many people there, but the output is very small. In fact, if you're talking about giving feedback to Ministry of Health, when you publish it, everybody can access that. So it's not a big issue in terms of providing directly. And we are not so sure, there's no evidence to show that whatever research being done in the institutions are being absorbed by the MOH to turn into policy. Research, good quality research are not coming from there. It's coming from the universities. And this is what changed the program. For example, when MOH asked us to support our promotion for the health financing scheme, they asked us the research on willingness to pay, ability to pay. These are done by my team in the university that we provide to them. Research on cost for healthcare for reimbursement, it comes from us, you know. So there are gross lack of capacity within the MOH to do this research. Yeah? So in order for us to actually enhance this, it cannot be done within the MOH. And furthermore, there is a real conflict of interest. If you are in that organization, you do research, you would only publish something that actually says good about your system. You are very scared to criticize your system. So at the end of the day, we thought that everything is fine, everything is good, you know, because you wouldn't write something which is critical about your organization. So this is the dangerous. It has to be independent. It has to be outside the organization.
Thank you for that, Prof. Aljunid. Any other questions? Yes, Professor Tipawan.
Thank you very much for your nice discussion and give us a very perfect scenario. So I would like to get your three expert on this field that we cannot avoid that now we have affected by the politics of health. And we are academians. I would like to ask three of you that what is our role and responsibility that we can do related to the research, that how we can improve the health system and policy of the country? Because in our country, we have the different scenario related to the politics. So I would like to ask about that question. What we can do related to research to link to the politics of health related to health system and policy.
Maybe Prof. Supasit and Dr. Lutfan can respond to that. Can you rephrase your statement a little bit to be?
So nowadays we know that in each country we have different politics, and we already know that politics is very influence health system and policy. We are academians. What we can do in the future that we can improve the health system and policy of the country.
Policies. How do we contribute to the policies in
Yeah,
that
sure.
sense of each country? What this group's role in that sense,
Yeah,
this
Sir.
tripartite combination
of us
can
in this
do?
room. We are the academians. How we can do better.
So like I respond that research on power and what power can be information power, information on quality. So what is acceptable to the people about family medicine? What quality of telemedicine that we would like to have, and yeah, we just stay. I think it's identify the gap, such as identify the gap and try to make a research questions in the package form, so that we're looking at many aspects to lead to the better health situation.
May I say a little bit about the sensitive issue in Thailand about the topics now, cannabis, Ajahn?
Yeah.
For the Thailand now, we have quite the issue of cannabis nowadays, that whether that we have the evidence and we show this one, and when we implement it, there will still something like the difference. So this one give just one example that what is happened related to politics of health.
Yeah, in terms of cannabis,
Change policy.
the
Sudden
research.
change in policies at the recent moment about cannabis use. Is that what you're trying to say?
Yeah.
But it's sensitive issue, I understand.
Sensitive in terms of politics, because we have new health ministers, but the previous health minister who endorsed the cannabis policy is the leader of the coalition government, and he gained a lot of power in the upper house. So it's a complex political, but in terms of research, some academia that I met last month, he told that the information that show is not genuine, not robust. Yeah. So meta-analysis or systematic review might play into our network.
Indonesia?
I think being an academia is have an advantage that we are independent. So if we do the research based on the good research practice, then actually we can tell the truth. Whether then the politician will use it or not is another story. But I think, we can tell something which is then expected to be have a moral value as well. And I think the politician maybe have another story, but I think we are on the position which is we can actually tell something which is hopefully good enough if we do the research based on the good research practice.
It's back to evidence-based, isn't it? So
Can I just make one comment on it? It's interesting question that you said that the role of academia in policy, and you mentioned by independent. researchers are independent, but what we can see is that there are two camps that you can join. I have produced 46 PhD students before. Yeah, some of them decided to join the dark forces. So you can join the same group or you can join the devils, you know. So in Malaysia, our current problem is not cannabis. Our problem now is vape. Okay. Vape is a big problem. We know that there are a lot of vaping, the electronic cigarettes. Yeah? A lot of issues on that. Politicians have been divided. Some of them support, some of them don't support. And from our public health perspective, we know that it is bad for health. But somehow some of our researchers, it happened to be some of my students, maybe not many, decided to join the dark forces and supported the vape industry. And they do a lot of, to promote this. This should not be done. So if you want to do that, I think please think about the ethical perspective. Previously, when we signed the FCTC, we know that there are certain academia who actually were listed as white coat. These are people who receive money from the tobacco industry and do research to show the good point about having cigarette smoking. But now we have vape. There's some people, they are academia, they are independent, but decided to accept money from tobacco industry. You know, vape industries now, many of the vape industries have been bought over the shares by the big tobacco industry. So they are equivalent to the big tobacco. And this is against our FCTC. So I think, please, you must have a clear conscience. If you are academia, try to do ethical practice. Try to implement it. Don't join the dark forces. Don't join the devils. Let us work together for public health. Otherwise, I don't think we're going to have a good scenario, a good situation in the future. We must maintain public health. Common sense is very important. If you know that that is bad, don't support that.
Thank you.
Yeah, I think to add to that story, I think when Thailand made it legal to sell cannabis over the counter, I think a lot of Malaysians decided to go for a holiday in Thailand, both in the dark force and in the clear force itself, bringing families. I was one of them in Hadia last year. Didn't buy any, but I saw some nice shops selling. So, but then there are commercial values, there are medicinal values in cannabis, because when I was in Adelaide, there was these family doctors from Australian family doctors who did some research, and they said it was good for central nervous system disorders, epilepsy and all that. So there was some evidence, but those are not, this belongs to a certain class of cannabinoids, you know, so not on the general term. So there are uses, but I think it's all back to evidence-based. And I know as you were saying, a couple of Malaysian doctors who are residing in Australia who are using vape as an alternative with evidence-based statistics, or just leave it as it is. Now, ladies and gentlemen, I think we've reached to the time that we've allotted for ourselves here. And I think it's been a fairly good discussion. But again, I think for us Malaysians, we've got Prof Aljunid here to lead the team, and I hope kita semua balik ni solat hajat banyak-banyak lah ya. 30 years, I want to see this through before I retire. 69, one more year to 70. 4 grandchildren, another one coming up soon. So we're on the same boat, Prof Aljunid and I. We've been apa kata sampai Leo sama Lele, what do you call that? So up and down, we've been fighting for different causes, but objective is the same. So it's a bit surprising, it's a bit disappointing to see that with only 30 million people, our neighbors is 270 million and Thailand is 90 million, is that right? 90 million or 70 million? And we are just very good at talking and talking and talking. So it's a bit disappointing, really. And I think our academics have been doing well, but our politicians don't, sorry to say that. So balik, semua kena balik solat aja lah, yes. All of us, I think let's make it a reality once and for all, because they've got the right technical advisor. I think we have the right person in place now, the right group of politicians. Let's all see this through. And I have been involved in this group for the last few years since I took my thesis under Prof Aljunid, and pretty happy that I come from a different sector, and joining this focus group, it expands my thinking, my horizons, and more contribution to national, international agendas. So I'm glad that we are making friends now. We get to know one another better, but the objective is the same. I happen to be the ASEAN Secretary for the ASEAN Regional Primary Care we established in 2007. So if you're going to expand it as it is, I think it can be part of the RPEC program. We call it RPEC. That was in 2007. Ismail Marikan was on the DG and Chua Saleh was a minister. And I was the one who was, in the words of the my Indonesian colleague, Pak Husni is the secretary sampai kiamat katanya. So I don't know, but we take turns in presidencies, you know. So let's get this through. It's been very informative. It's been very good exchange. And all of us have this common agenda that we want to see this region progressing together. So let's all make it work and get to more. We look forward to being Jogja next year, and I hope we'll see more of you and more Malaysians. I think Ibu somebody was asking me berapa tahun ini berapa puluh Indonesian kami berapa orang ke Malaysia ke Jogja tahun depan. Saya bilang kalau saya ada my own jet, I'll bring 100 doctors. So I don't have my own jet, so can't promise. But we look forward to that. Let's give a round of applause and appreciation usually to our very good speakers. It's been wonderful exchange. Thank you all once again, and to all those who have, if you have any other questions, perhaps you can offer them directly to the speakers later on. Thank you. Assalamualaikum warahmatullahi wabarakatuh.